And basically in this particular study, they had very similar recurrence rates. So almost 400 patients with a 40% recurrence at 1.5 years post-surgery, really showing that a very similar recurrence rate to what we saw in Adelaide, Australia. Where do polyps occur? Well, they recur, as we expect, in the frontal sinus mainly. And we believe this is due to the fact that we probably have very difficulty in removing all the disease from the frontal sinus at the initial procedure, unless you're doing a Lothrop or a drill out procedure. And also, obviously, these regions are the narrowest where polyps can recur without the topical steroids getting in post-operatively. Once the frontal sinuses set in, the ethmoid cavities then obviously become populated with the polyps. And really the dependent sinuses, the maxillary and the ethmoids, where the steroids get to post-operatively, have the lowest rate of polyp recurrence. So what we also analysed in those two studies was the risk factors for recurrence. And in our particular study, our 10-year retrospective study, if the patient had previous surgery, if they had asthma or aspirin exacerbated respiratory disease, these were all independent predictors of recurrence. And if you had all three, then the rate of you getting recurrence was almost 100%. If we look at that second prospective study from the US, having had prior surgery was a risk factor, as was worst preoperative disease. Now, the reason why FES fails is for two reasons. One can be technical, where the surgery is not performed properly. And here you can see a patient who's had this very limited surgery. The uncinate process is still intact, and really they've only had maxillary antrostomies. So this is a reason for failure, because we're not getting rid of the inflammatory burden and we're not allowing access to the sinuses with the irrigations. But what I want to speak to you about here is the patients who have well-performed surgery. And these are patients who fail despite having had all their sinuses opened up properly. Now, there are many reasons as to why these patients fail, whether it be bacterial biofilms, enterotoxins, fungus, eosinophilic mucin, there's a whole host of reasons. But what they share in common is that these patients have a very high inflammatory burden of disease. And so this brings me on to the concept of the inflammatory load hypothesis, as well as the irreversible disease hypothesis. And I'm going to speak about both of these topics because they're relevant to the management of these patients. They're both interlinked. Now, the inflammatory load hypothesis is really centered around the finding that if we have a higher level of peripheral or blood eosinophilia or higher tissue levels of eosinophilia, these patients have more disease on endoscopy and on CT scan preoperatively. And this is well documented in multiple studies. What we've also since found, aside from the inflammatory grade correlating with disease severity, is that peripheral and tissue eosinophilia also correlates with surgical outcomes. So patients with more disease in their tissue and peripherally will also have more disease post-operatively and more likely to recur. And in order to understand this, we should look at the eosinophil. Now, in European, Australian polyps, the eosinophil is a driving factor. This cell has more than just an inflammatory function. It acts as an antigen-presenting cell, it can elaborate in cytokines, and it can also attract more eosinophils to create more inflammation. It leads to tissue eosinophilia through the release of eosinophilic cationic proteins and substances that destroy the tissue. And if you leave eosinophils behind at that initial procedure, you'll get this cycle of inflammation continuing because these eosinophils will create autocrine persistence or more and more inflammation through the attraction of more and more eosinophils. With time, if the inflammation persists, the disease becomes resistant to steroids. And this is where we get irreversible disease. We get irreversible remodeling where the patients no longer respond to oral or topical corticosteroids. We've also seen in some studies that these patients elaborate steroid-resistant mechanisms where they can actually have efflux pumps that remove the steroid from the cell. Now, if we look at the lower airway, patients with asthma, this irreversible disease hypothesis has been well described as far back as 1992. We know that in asthmatics, if we don't treat the inflammation, the reversible inflammation that responds to bronchodilators starts to become remodeled, and eventually we get irreversible disease. These are respiratory cripples that no longer respond to salbutamol or bronchodilators or steroid medication. And it's for this reason that the asthma guidelines have changed. Before 1997, we only treated patients with daily corticosteroids if they had moderate or severe disease. But following the understanding of this irreversible disease hypothesis, the whole concept of treating these patients changed for treating them if they had any symptoms on a daily basis, no matter how severe they were. So now we recommend that if patients have mild but persistent daily symptoms, they should receive inhaled corticosteroid therapy. And the reason for this is that with prolonged inflammation, we get irreversible disease changes. And this photomicrographs of histopathological specimens taken from patients with sinusitis. What we can see is that at the top of the screen, we have elaboration of the goblet cells and the mucus secreting cells, and these are the reversible changes. But with time, this sinus cripple, this end-stage sinus patient who's had inflammation for over 10 years, starts to get basement membrane thickening, and the submucosa is replaced by muscle fibers and scarring and fibroblasts. And so this patient no longer responds to the corticosteroid therapy. Eventually, these patients will obviously become respiratory cripples. So we want to try to arrest the process before we get this irreversible remodeling occurring. Do we have any data to support these pathological changes? Well, we do. And this was the study done by Claire Hopkins and Valerie Lund, which looked at over 1,500 patients in the NHS in the UK and their time to treatment. This is a really well done paper with really good results. And what they found was that if you looked at patients in terms of when they were treated from the time of diagnosis to treatment, patients who were in that early cohort, those who received their surgery within 6 months of diagnosis, did much better long-term and much better with the initial procedure. So they got a benefit from the surgery, and that benefit persisted. Patients who had a delay to their treatment of over 12 months in that mid-cohort or over 5 years in that late cohort ended up not getting the same response from surgery, and their symptoms deteriorated in the 5 years following surgery as well. So by operating on patients early, getting rid of the inflammatory load, you actually predispose these patients to a much better surgical outcome and a much more sustained response from surgery. So this brings me on to the management of these polyp patients post-operatively. And this is really the focus of this talk. So we all know what polyps are. Polyps are inflammatory tissue, but polyps are different. We can have polyps which are eosinophilic, and we can have polyps which are neutrophilic. And these neutrophilic polyps are the ones that we see predominantly in the Asian population. Now, when we send off a specimen for our histopathologist, we really need a lot more information than they usually give us. In the past, we would send off a specimen and they would say, this is a benign polyp consistent with sinusitis. But we know that. We know that polyps invariably are benign unless we're suspecting an inverted papilloma. What we need to know is a bit more information about that polyp. And by having this information, we can then tailor our care post-operatively for these patients. What we ask for all of our patients who have surgery is to get an idea of the level of inflammation, the eosinophilic count, whether or not neutrophils predominate, so what is a major inflammatory cell, and whether or not there are any irreversible changes occurring. So not only can we tailor our medication, but we can also counsel the patient on their long-term prognosis following surgery. And so if you don't have a histopathologist that gives you this information, get a new histopathologist, because this is really important in modern day treatment of polyp patients. So with regards to the histology synoptic, what I want to know is this essentially in the short term: how much inflammation and what is the predominant nature of inflammation? Now, as we said before, for polyps, the most predominant inflammation is eosinophilic, And these are the patients who respond really well to topical budesonide corticosteroid therapy after surgery. As I said before, I also want to know about this irreversible changes. Is there basement membrane thickening? Is there squamous metaplasia? Is there scarring or fibrosis occurring? So I can counsel them in the long term. So as I said, if it's eosinophilic, I put these patients on budesonide post-operatively and twice a day, and I keep it on them until their epithelium returns to normal. Once the epithelium has gone through that healing stage and the tissues look healthy and normal, I'll then start to taper down the medication. This normally occurs within the first 6 months, but in some patients, if it doesn't occur, I keep them on the budesonide because I know that as soon as I take the foot off the accelerator in terms of treatment, they will start to get polyp recurrence. So the question that people ask is it safe to use budesonide long term? Well, we have no drama at all in telling our patients that inhaled corticosteroids or topical sprays are safe. And if we look at the total daily dose of a steroid spray, we can see that we're delivering directly to the epithelium about 400 micrograms per day. And long-term studies have been done on sprays, and we know they're not absorbed. We know that they're safe. When we give budesonide, we're delivering a total daily dose of about 500 micrograms per day. So you might say that this is in excess of what's been studied in the sprays, but the reality is the amount of the actual steroid that stays within contact with the epithelium for any prolonged period of time is only 3% of that whole irrigation. 97% is washed out within the first 2 or 3 minutes of irrigating. 97% goes down the basin of the wash bowl. So in essence, we're giving a patient 15 micrograms of daily steroid, well below the safety of what we're giving when we give a spray that's entirely retained within the nasal cavity for at least 15 minutes. This has been studied long-term with studies out of Stanford and also out of Canada. And both studies have shown that HPA suppression is really negligible. The second study did show that asymptomatic hypothalamus pituitary adrenal suppression does occur in some patients, but these patients were all patients also receiving inhaled corticosteroid therapy for their asthma. Pleasingly, as soon as either the inhaled corticosteroid or the topical budesonide was stopped, the suppression reversed and there was no further suppression. So it's a reversible change that occurs. Importantly, in that study, there were no increases in intraocular pressure or other adverse effects of chronic steroid use. Are these medications effective? Well, the studies are all there. The top two are prospective double-blind randomized controlled trials. The bottom one is a cohort study. And what all the studies show with significant numbers of patients is that patients on topical steroids in an irrigation form after surgery do much better in terms of their endoscopic scores, their Lund-Kennedy endoscopic scores, and their symptom scores. And they get a much greater improvement in their overall quality of life as well. Now, what about the patient who doesn't have eosinophils? Do we give these patients topical steroids the same way that we give the patients who have eosinophils? Well, the answer is probably not. They're not as steroid responsive. So when I get my histopathology synoptic back, I want to have a look at that predominant cell. And if it's not eosinophilic and it's lymphocytic or neutrophilic or lymphoplasmitic, which is a new term that pathologists are using, I start to think about different management for these patients. In my experience, these patients are a very unique cohort. These patients get very early polyp recurrence. They're often steroid resistant, so topical steroids don't seem to work in this group. And they often have this thick white mucus that drains from their sinuses bilaterally. And this is a patient who I operated on 8 weeks prior. And here you can see, it almost looks like I haven't done surgery. You can see that we've still got the cautery where we've done our radical antrostomy and we've cauterized that middle turbinate stump, inferior turbinate stump, but we've got this sort of polyp appearance in the middle meatus and the ethmoid cavity. And these are quite depressing because I'm pretty sure I know how to do surgery. I'm pretty sure I cleared all the disease. This is that same patient 3 months after oral macrolide therapy. The polyp has completely gone. We can see that the surgery has been done well, and we can actually see all the partitions up into the frontal sinus. And so this was simply by using macrolides. Now, that patient, I had tried everything in before macrolides. I tried them on topical antibiotic washes, oral steroids, topical steroids, you name it, they tried it. And it wasn't until I threw the macrolide therapy at them that they got better. Here's another patient. This patient is a patient who had polyp recurrence at 4 months. Again, very depressing. Have I actually done reasonable surgery in this patient? You can see that the tissue is very indurated. There are polyps everywhere. It's really a depressing state. So this is that same patient 3 months post macrolide therapy. This is a patient, again, with neutrophilic inflammation. Here you can see that there's still edema, but the polyps have resolved, and we actually can now see into the frontal sinus. We can see the skull base, and we can see the maxillary sinus. So although it's not as good as that first response, this patient has certainly responded to the way that they don't have the symptoms or the polyp disease that they had previously. So this made me look at macrolide research a bit more closely. And obviously 10, 15 years ago, macrolides were the big thing and very commonly used in Europe. And this was based on actually a study from Queensland in Australia by a colleague of mine and a good friend, Ben Warwick. In his initial study, they basically found that patients randomized to macrolides seemed to do really well post-macrolide therapy in terms of their symptom scores, the endoscopic scores, and their saccharine transit times. Patients with low IgE, so these are the non-atopic patients, were the ones that seemed to do better. But they just observed that. They didn't delve into the explanation as to why that was the case. If we look at a meta-analysis done by a Thai group, when they looked at patients with and without polyps, they said that the patients that tended to do better with macrolide therapy were the non-polyp patients. So patients generally with neutrophilic inflammation. Polyp patients, as we said before, generally have eosinophilic inflammation. In this group, they looked at all the different types of macrolides, and they found no difference between the different groups of macrolides or different types of macrolides, provided that you were using a dose at least 50% of the recommended antibiotic dose. Now, if we look into the research a bit further, there's been a really nice meta-analysis that's looked at polyps, depending on whether or not they were from Asian studies or non-Asian studies. And here we can see in the top graph that the Asian polyps have a much better response to macrolides than the non-Asian polyps. So all of the studies where macrolide therapy was shown to be not effective were the European studies, whereas the studies where it showed that macrolides improved quality of life, symptoms, and endoscopic scores came from Asian groups where there were neutrophilic predominance. And the reason for this is, as we said, Asian polyps aren't eosinophilic driven. They are driven by neutrophils, similar to chronic rhinosinusitis without nasal polyps, which is mainly a lymphocytic driven disease. So the immunomodulating activities of macrolides are very well documented. And this was taken from the Lancet Respiratory Medicine. And you can see that macrolides work on a whole host of downstream systems to affect inflammation. And I'm not going to go into the details of how macrolides work, but we know that they do work. There is a word of caution, and this was just released in 2018 from the FDA, that clarithromycin does have a risk of causing sudden cardiac death if it's used in a patient with a history of ischemic heart disease. So before you're going to put a patient on macrolide therapy, make sure that you have a risk profile in terms of their cardiac risk and make sure they've got no strong family history of ischemic heart disease. So then obviously we have the group with aspirin exacerbated respiratory disease. And these are the patients who have polyps, they've got asthma, and they have a reaction to non-steroidal anti-inflammatory medications. We know that it's due to issues with their inflammatory pathways, and as a consequence, they have severe inflammation. And I'm sure you've all seen these patients in your clinics with polyps almost coming out of their nose and complete opacification of their sinuses. These patients have very severe sinus disease on the end spectrum. They've got difficult to control asthma, and about 3/4 of them can get symptoms when they have alcohol, particularly white wine, because white has a high level of preservatives and sulfites. These patients have a high distribution of allergies, and they've got a lot more tissue and peripheral eosinophilia than standard patients with nasal polyps. Their rate of recurrence is about 10 times higher than their polyp counterparts. So should we diagnose these patients, and how do we diagnose them? Well, we diagnose them with an aspirin challenge. And I found this a really interesting finding. If a patient does have a history of non-steroidal anti-inflammatory hypersensitivity or intolerance, 90% of them will get a positive challenge to an aspirin challenge. Interestingly, though, a lot of patients who don't report symptoms when they have aspirin or other non-steroidal anti-inflammatories, 42% of them will have a positive challenge, despite telling you that they have no issues when they take these medications. And the reason for that is often they're on other medications that will block the symptoms that one would expect when they have aspirin. And sometimes they've got such bad inflammation that they're actually insensitive to the reaction symptoms that they typically get. Their wheeze is always there. Their difficulty breathing is always there, that they don't perceive a difference when they have aspirin or non-steroidal anti-inflammatories. So therefore, in any patient who presents to me with severe asthma, a Lund-Mackay score greater than 12 with the presence of polyps and high levels of eosinophilia, I will get an aspirin challenge, irrespective of whether or not they tell me that they have an intolerance to non-steroidal anti-inflammatory medications. Now, the evidence for the treatment and desensitizing patients is there. We know that surgery, sinus surgery, improves the lower respiratory tract reactivity during aspirin-exacerbated respiratory disease. And so these are two studies that show that if you do surgery prior to desensitizing a patient, they tolerate the desensitization process much, much better than if you did the desensitization prior to surgery. And it's believed that you get less of the release of the inflammatory cytokines that the desensitization process causes. We also know that patients who have surgery prior to undergoing desensitization actually have much better responses to the aspirin desensitization process than the patients that haven't had the surgery. And we believe this is due to the fact that we're creating more controllable disease. We're removing the inflammation so that there's less inflammatory treatment needed. And so this particular study looked at patients who had failed primary desensitization, and they looked at those patients, and then they performed surgery on them, and then they tried desensitization again. And in this particular study, those patients, the majority of them succeeded the second desensitization attempt because they'd had their inflammatory load reduced with surgery. So just because a patient has failed desensitization once, don't give up on them. It's really important that you try again, but usually about 4 weeks after performing endoscopic sinus surgery. Now, there are risks associated with aspirin desensitization, and really it's the gastric side effects that limits their use. We know that patients that do tolerate desensitization have much improvement in their quality of life, but a considerable portion of them need to stop due to the gastritis that they experience as a consequence of the therapy. There is hope for these patients. There are now studies that suggest that low dose aspirin desensitization can actually still give some benefit. You don't need to be using the 300 to 600 milligrams twice a day to get benefit. In these patients, 100 milligrams or a baby aspirin can still give them benefit in terms of disease control. And in this particular study, which was a double-blind placebo-controlled trial, they showed that the patients on low-dose aspirin, 100 milligrams per day, still had a much reduced risk of relapse than the placebo group. I know that biologics is probably something that will be spoken at another one of these meetings in more detail, so I'm not going to go into a lot of details, aside to say that really biologics have come to the game. And this is a way that we can target specific downstream problems without getting the systemic side effects of corticosteroids, which dampens the entire inflammatory profile. Obviously, there are lots of different ones on the market. In Australia, we can't prescribe them as ENT surgeons. I know that in Europe you can. We require to get them from the respiratory physicians and use the improvement in the sinuses as a secondary effect. But I think as ENT surgeons, we really need to be familiar with the data to be able to answer the questions and also prescribe these medications, as I think they are a real game changer for patients that don't respond to the other medical therapies that are recommended. Obviously, there are some really good studies coming out now, and this is the study by Klaus Backert's group, which is significant evidence to support the biologics. And again, I won't go into the details because I'm sure it will be described, and we are running out of time. But they showed that patients with treatment refractory chronic rhinosinusitis with nasal polyposis treated for 24 weeks or up to 52 weeks did significantly better in terms of disease control than patients randomized to the non-biologic arm. And this really just summarizes the analysis of 724 patients. And we can see that, both groups, the 24-week treatment and the 52-week treatment, did exceptionally well. And the treatment responses were maintained out to follow-up at a year post-commencement of the treatment. Obviously, we need to look at secondary outcome measures, not just symptom scores, and they improved in terms of their endoscopic scores, particularly their smell, rhinorrhea, and their asthma control as well. Obviously, biologics are expensive, so it's really important to reevaluate these patients when they're on the biologics, because not all patients will respond to them. And the Euphoria document describes this really well in terms of which patients we should try it on and when we should monitor these patients for a response. And these guidelines are readily available on the EPOS document, but also on the Euphoria consensus statement. Essentially, after 16 weeks is the time that you should reassess them, and yearly after that. And if they're responding, keep them on the medications. If they're not responding, that's when you should stop them. And so, in a nutshell, this is the way that I treat these patients. I think we've got some really good evidence to support our treatments, and I thank you for your attention.
Thank you, Alkis, for the presentation. A glance, I would say, with all the information needed for the specific treatment, not only for surgery, but also for, as you said, a personalized treatment based on the findings. So we have plenty questions. Some of them you already replied to them during your presentation, but some of the others not are more specific. So let's go for the first one. This is coming from the US. And our colleague is saying, what is your post-discharge management of a patient operated for functional endoscopic sinus surgery with an NPS score equal to 8 from day 1 up to 2 weeks?
With an NPS score? Can you?
NPS score equal to 8 from day 1 up to 2 weeks.
Sure, yeah, okay. So I have a low threshold to put my patients on oral corticosteroids post-surgery. For my polyp patients, it's a no-brainer. So I'll have them on prednisolone or prednisone, 25 milligrams a day for a week, 12.5 milligrams a day for a week after that, and 12.5 milligrams alternate daily after that. I see them at 2 weeks, and at 2 weeks, I commence them on budesonide irrigations, 1 milligram per 2 mils. I get them to empty half a vial of that into a full bottle of saline irrigation, and they irrigate a full bottle on each side. So they're getting 1 vial split between 2 bottles, and they're doing that twice a day until I review them again in 6 weeks' time. So I review them at 2 weeks and at 6 weeks. If at that first post-operative visit, the histopathology suggests that the patient has lymphocytic or neutrophilic inflammation, I already will write in my notes, consider macrolide therapy if they are having ongoing inflammation at their second post-op. That's at the 6-week mark. For my non-polyp patients, I have a very low threshold for prednisolone as well. because I think prednisolone really improves post-operative healing. Unless there are contraindications, like the patient is diabetic or they have mood swings or obviously mental illness, I will put them on a 1-week course of prednisolone, just 25 milligrams a day for that first week, because I just do that to facilitate healing. In terms of antibiotics, I put all my patients on post-operative antibiotics, but I will say to you, Puya, there's no good evidence to suggest that post-operative antibiotics actually do anything other than make the surgeon satisfied. And so there are studies that are being done at the moment that I'm aware of, which will tell us whether or not they actually have a benefit. If I'm going to use an antibiotic, I like doxycycline. I think doxycycline has got good anti-inflammatory profile against the MMPs, matrix metalloproteinases, and they're very well tolerated. So that's the one that I'll generally use in the early post-operative period.
You're not the only one. You're actually the third in a row saying the use of antibiotics post-operatively. The first one was Biscuit, and I got last week David Kennedy, and now you. So this would lead my question: is that why, if the majority of the study that has been carried were telling to not there are not discrepancies between the usage or not usage, but we are finding out this huge difference. As you presented your images was like very fascinating to me. The majority of are seeing those patients not being sufficiently treated after surgery in 2 weeks, then suddenly after usage of antibiotics those polyps like disappearing. So it looks like those antibiotics would change, and it's reminding me that, is it possible that, as you said, is it based on a geographic area that the usage of antibiotics will lead you to have a different results, since those studies has been carried, for example, in Asia and the others somewhere else? So you already replied to the other question, which was, are you using spray or nasal douches for steroids?
So nasal sprays are a rhinitis treatment. Studies show that they're not penetrating into the sinuses. So what they do really effectively is treat the head of the inferior turbinate. So they help with nasal congestion. That's it. Because they don't penetrate the sinuses, you get no steroid effect in the ethmoid, the frontal, or the sphenoid sinus. So I don't use them post-operatively. If a patient's got rhinitis and they're stable and they've got no signs of inflammation in their sinuses for many years post-surgery, but they get rhinitis, that's the only time I'll use them.
Vizcaya said a bad example of this. I mean, a good example of this is like, if you putting spray on your hands will be enough for cleaning your hands. Of course not. So you need a good amount of water to clean your hands, and the same would be for your sinuses. Actually, she was saying that the volume of your sinuses is equal to a hand, so that's why you need nasal douches. Other question
on that point, Puya, when you do nasal douches, it's really also important that the volume you deliver is greater than 100 mils. So there's no point in putting half a bottle on either side, because the studies show that the frontal and the sphenoid sinus do not get penetrated unless you're using 100 mils to generate the pressure and the volume to get up there.
I remember there are studies that are also showing the different, not only the douches and what different douches are you using and where they are penetrating in the upper meatus, then the flow that has been carried if you use in different positions. So yeah, I really do agree that the device and the modality that you use in would make the differences. Our other question from France, I was saying, are you using antihistamine or in combination with steroids after surgery?
So yeah, we have a combination spray, a topical antihistamine as elastine, and a steroid in one spray. And these are really effective, again, for allergic rhinitis or patients with histamine responses, so atopy and so forth. So I will use them in patients with hay fever, seasonal rhinitis, they're not really that useful in patients with polyps, to say the truth. Now, the interesting thing is, if you've ever had an antihistamine spray, it's really, really bitter. And patients often say they can't tolerate the spray because it's bitter. New evidence suggests that the benefit of the combination spray isn't just the antihistamine and the steroid, it's the activation of the bitter taste receptors, the TRV1 receptors, because they're protective receptors that upregulate the body's ability to fight pathogens. So they think the added benefit that these combination antihistamine steroid sprays have is through the activation of that bitter taste receptor pathway as well.
Fantastic. It was actually the question after this, and these colleagues from Portugal was asking exactly this questions. So you replied completely to this. Let's go to the next one of Brazil. And the colleague is saying, are you routinely performing frontal sinus surgery?
Yes. So I perform, most of my practice is tertiary practice. So I often perform it. If the patient has inflammation around their frontal rhesus, I don't believe in just doing a maxillary antrostomy and anterior ethmoidectomy. I think that is the kind of surgery that people who aren't comfortable performing frontal sinus surgery tell everyone, so that they don't have to perform frontal sinus surgery. You treat the inflammatory burden. The more inflammation you can get out at the time of surgery, the more you can access the sinuses with topical washes after surgery. You're increasing the distribution of the washes, the more likely you are going to get that patient to return to sinus health. So what we're doing is we're not curing a patient. Surgery doesn't cure them. It basically facilitates disease removal, but most importantly, access to the sinuses for topical steroid medication post-operatively. So in answer to that question, if a sinus has inflammation, it needs to be opened so that the wash can get to the site and treat the inflammation.
Question from Italy, how you perform aspirin desensitization?
So it's performed by our immunologists and our allergists. I don't perform it per se, but essentially there's two ways of doing it. If the allergist deems that the patient is at high risk of anaphylaxis, it will be performed in hospital with a 24-hour challenge. If the symptoms are very mild and the allergist doesn't think that they will get symptoms, they often send them home and get them to start on low-dose aspirin desensitization with antihistamines and other medications to suppress the reaction. Generally, the allergists, in my experience, try to push the dose as high as they can at the beginning, so to whatever's tolerated. And that can be 600 milligrams twice daily, which is really a high dose of aspirin. And again, in my experience, most patients can't tolerate 600 milligrams twice daily for too long. So you get them on whatever they can tolerate. And that study, which showed that low-dose aspirin of 100 milligrams was still beneficial, for me was reassuring that patients shouldn't just give up on it if they don't tolerate the high doses.
All right. The next one is from Sweden. Asthmatic patients with chronic rhinosinusitis would have benefits more from omalizumab or dupilumab?
So good question. Anecdotally, dupilumab is my favorite. And I think the evidence from the studies by Bacart show that dupilumab probably has the best evidence and the best profile for our polyp patients. It makes sense to me, and that's why I like dupilumab. I don't know if we've got enough head-to-head trials of omalizumab versus dupilumab directly against each other in the same patient cohort, but I think they're all good. Anecdotally, I prefer dupilumab, but that's only based on that paper that came out of Bacart with 700 patients.
Well, I think that we will see the differences in the future for dupilumab, since omalizumab has been, we have more data in regards to that. So for the dupilumab, we need more studies and more time to see the real effects and the long-term effects, of course.
Exactly.
And in regards to this, from France, that they are saying, are you suggesting to keep continuing nasal steroids after the usage of dupilumab?
That's a really good question. I add dupilumab to the nasal steroids. So when they're on nasal steroids, if they start to fail, that's when I'll get my respiratory colleagues involved to give dupilumab. Now, at a certain time, when the sinuses start looking good again, that's when I start bringing the nasal steroids off. So I titrate the steroids according to what I see endoscopically and to what the patient tells me. If a patient comes off the nasal steroids and their polyps and their edema starts to come back, I go back up to the dose that controls it. So my maximum dose is twice daily, but I've got some patients who take steroids once a week, and some irrigate with steroids once a week, and some patients that irrigate it with it every second day. It's again personalizing the treatment to what you're seeing. So really important to tell your patient when you meet them, this is a lifelong treatment. I'm going to manage you like your cardiologist manages your blood pressure, or like your endocrinologist manages your diabetes. We have to see each other regularly, even if you're feeling good, for me to have a look at your sinuses, because often there's a delay between symptom and endoscopic findings. So if I start to see inflammation, that triggers me to get you back up to a higher dose of topical steroids until we've got through that initial phase, and then I'll bring them down again. I also tell my patients that if you get a viral infection, go back up to twice a day with your topical budesonide for 2 weeks, even if you're only on it once a week, because I really think that that initial viral insult causes that dysregulated inflammatory response, which then perpetuates the inflammation. So trying to control our response to viruses is the key.
I really love the comparison with the cardiologist, like a long-term follow-up and talking to the patient, like you're have a fidelization of that patient and the doctor. The combination of those two is very important to have a better management. So the relationship that should be built is the fundamental for you and for the benefits of the patients. I think that we don't have enough time. I just want to make sure we can reply to this one from Egypt. Oral steroid before or after surgery?
So we do research on all of our patients. So we have no steroids before surgery because it excludes them from research into their inflammatory cytokines. There's good studies to show that if you give a week of steroids preoperatively, orally, or if you give twice daily dosing of a steroid spray, there's less bleeding and a reduction in surgical time intraoperatively. So if you've got a patient with lots of polyps and you're not doing research on them, give them a week of steroids before surgery, and your surgery will be a lot easier to do because you'll get less inflammation, you'll have less bleeding, and you'll probably be able to do the surgery safer. But continue that steroid post-operatively. So if you have it on 25 milligrams daily for a week preoperatively, continue that maybe for another week after, and then start titrating the dose down.
Great, thank you. I'm very sorry for this short time. There were plenty questions. If anyone would ask any other questions, you already have our social media platform. If anyone interested, you can type your question. I will try to get him managed with Alkis directly. I will send him an email so he might be able to reply. Don't forget, due to these difficult times and we were not able to perform cadaveric dissection courses, but hopefully in the future, those one will be restored. And if you have some interest, I remember every attendees to keep continuing their educational trainees with dissection courses. And in the future, as soon as the Australian border will open up, I'm probably confident that Alkis will be around in a word to perform and to teach endoscopic surgery to the younger generation and to the residents. So keep informed, go to the university sites from Alkis, and you will be able to attend or to get informed for future activities. Are you suggesting anything for the near future from your side?
Yeah, so we've developed these 3D printed models, which we now teach, where you can basically go through easy surgery, more difficult surgery, based on the anatomy configuration. And we've just developed our first tumor models. So we've got inverting papillomas, we've got a pituitary tumor model. So you can basically do a complete dissection of a tumor at our courses. So hopefully when the borders open, we'll have you, Puya, as an honored guest speaker. And we can even share these models for your course if you ever want them, because I think it's a nice graduated way of learning surgery in a stepwise manner?
Yeah, I think that we will probably import those kits in Europe from our association. So the collaboration will lead to a greater opportunity for residents to make their own practice. Before closing the remarks, I would like to remember the next appointment, November 17, Wednesday. We have Patricia Johnson from a WIR. She will talk about gender gap among rhinology and skull-based surgeon. I will remind all the attendees to keep attending that one too, and the future one. Thank you, Alkis, for your participation. I'm really sorry for the attendees. This is very early today and in the afternoon from your side. And I really hope that we can make for the next semester also not only a live but also a teaching schedule for frontal sinus surgery or virtual reality with your presence. Thank you, Alkis, again.
Thank you very much for having me.
Soon. Anyone interested, go on our YouTube channel or Facebook or Twitch, and you can watch it again freely anytime you want. Stay safe, Alkis.
Thank you.